Hello, everyone. This is Dan Duffy. I am the co-director with Stephen Crawford for the Oklahoma Primary Healthcare Improvement Cooperative. And welcome to the webinar on Beyond Pain Pills. We're really excited to be able to present this webinar to you today. I have a couple announcements before we get started. First of all, unfortunately, we are not able to offer continuing medical education credit for this webinar. It just wasn't possible given the short time frame to get all the paperwork done. Secondly, references and resources are attached to the end of the PowerPoint deck, and they can be accessed when you download the PowerPoint at the end of the webinar. We would like you to use the chat for asking questions, and we will go over them at the end of the seminar. So let's go ahead and get started. When we instituted the Do No Harm program, which implemented guidelines for safer opioid prescribing and chronic pain care into practices, we learned that there was a knowledge gap and actually a skills gap among many Oklahoma primary care practices. We had recommended that non-pharmacologic treatments be used in the multimodal pain plan. However, many clinicians and their staff were unfamiliar with how to teach patients these options and refer them to receive them. Therefore, through a generous grant from the Oklahoma Mental Health and Substance Abuse Services Organization, we, in collaboration with the OUTU School of Community Medicine and the Ann and Henry Zarrow School of Social Work, put together this particular program on Beyond Pain Pills. The learning objectives that we have for you today are to, one, use simple language to explain how the brain changes from physical or emotional trauma. Second, to motivate and educate patients with chronic pain to use methods to enhance natural pain relievers for their chronic pain. Third, enhance patient acceptance of referrals to learn these methods. And lastly, in dealing with trauma-informed care, we'd like you to learn how to de-escalate emotionally charged clinical situations. Our faculty today is an outstanding group of experts in these topics. Dr. Kim Kuhn from the Department of Psychiatry at OUTU School of Community Medicine, Dr. Martina Jelly, an internist from the same school, and Dr. Francis Wynn from the Department of Family Medicine at OUTU School of Community Medicine. And lastly, we have Dr. Julie Miller-Krebs, who is the director of the social work program on the OU Tulsa campus and also a member of the OUTU School of Community Medicine. So without further ado, let me move forward and turn the podium over to Dr. Martina Jelly.
Thank you, Dan. Hello, everyone, and thank you for joining us today. I've been a primary care physician caring for patients and helping train residents and students for over 30 years now, and I've cared for thousands of patients. Throughout today's presentation, I'm going to tell you about a few of those patients. Let's get started by going back to 1986, which was my intern year here at OU Tulsa. I had a patient in my panel who we'll call Maria. Maria was just a few years older than I was and came in frequently. You can tell that she left an impression on me as I still remember her 30 years later. Maria always had multiple problems to tell me about, lots of pain, back, abdominal, chest, knees, and other issues such as palpitations, fatigue. She went to the emergency room frequently, occasionally got admitted for chest pain. She was the patient that I dreaded seeing on my schedule. She was never satisfied with my suggestions for treatment or further evaluation. Long before the opioid crisis, she often asked for pain pills and benzodiazepines. She had lots of complaints about her situation of being young yet having so many health issues, although I don't remember learning a lot about her life outside the clinic or about her life before I met her, including her childhood. She was the kind of patient that left you drained and frustrated. If we ever did come up with an option for treatment that she would accept, another problem would pop up. I've learned so much about caring for patients like Maria in more recent years, but I do remember learning one thing from her. I learned that listening can be therapeutic. I realized in my third year of residency that Maria would be most satisfied if I would just let her talk, vent about her problems and how much she was suffering, would say classic things like, "This must be hard for you, and I'm sorry you have these problems," but I did stop trying to fix everything. So even though things got a little bit better with Maria, I feel like I likely misunderstood why she was like she was and the origins of her pain and her behavior. My attitude with Maria remained, "What is wrong with you?" I was frustrated that I hadn't helped her more. My colleagues and I would like to share what we and others have learned about patients like Maria and options for caring for them. I'll be back in a little bit to tell you about another patient that I've cared for more recently. I'll hand it over now to Dr. Frances Nguyen from the Department of Family and Community Medicine here at OU.
Thank you very much, Dr. Jelly. Today, I will explain the role of the brain and the mechanism of pain, and explain how this is affected by adverse childhood experiences and trauma. Scientific advances have transformed the understanding of the neurophysiology of pain, and now incorporates the impact of adverse childhood experiences, or ACEs, toxic stress, and trauma as critical components to understanding pain. What does this mean? It means that our experiences are written in our brains and bodies. To fully understand the mechanism of pain, we must incorporate a person's history, particularly that of trauma. This is moving from a stance towards the pain patient of asking, "What is wrong with you?" to asking, "What happened to you?" This is a trauma-informed approach to pain. First thing that we have to do as clinicians is shift the model of pain under which we have been working. We typically think about pain beginning somewhere in our body, like our muscles, bones, and gut. Then this sensory input travels to the brain where it is rapidly interpreted as pain. Let's look at this example of a finger stick. The sensation from the pin or needle travels towards the brain through nerves known as afferent neurons, transiting through the spinal cord. In this illustration, the spinal cord is not fully pictured, but rather we see one vertebrae up close to illustrate the pain pathway, where the primary afferent neurons travel through the dorsal root ganglion and ventral horn to the secondary afferent neurons. Pain signals are received in the sensory centers of the brain, the thalamus and sensory cortex, and are processed there as noxious or painful. If the signaling stimulus was a feather, signals would be perceived as benign or as touch. In terms of pain interventions, the volume knob for turning up or down the intensity of pain takes place in the spinal cord by either amplifying or inhibiting the transmission of pain stimuli through the dorsal horn cells. There are key neurotransmitters that downregulate pain in this mechanism. Our endogenous endorphins, such as the alpha, beta, and gamma endorphins, function to inhibit the communication of pain signals, working to decrease signaling along the afferent pathways, and exerting their analgesic effects primarily by binding to opiate receptors at presynaptic nerve terminals. These neuropeptides are the natural painkillers of the body, and they are primarily synthesized and stored in the brain, specifically the pituitary gland. Release of endogenous endorphins produces, for example, the runner's high that comes from vigorous aerobic exercise. The traditional mechanism of pain is applied usefully to acute injuries and disease, as well as chronic pain arising from identifiable pathology, such as osteoarthritic spinal spurs. But this is only a part of the story of how pain works. What we have now is a large body of evidence that tells us that the primary way in which pain is processed actually begins in the brain. This means that there are strong emotional components, cognitive components, and behaviors which influence how we experience pain. We need to shift to an understanding of how the brain is a major driver of pain experience through its own descending pathways. There are strong emotional components of pain, such as fear and anxiety, and this is processed in the limbic system, primarily in the hypothalamus and amygdala. Cognitive activities influence the pain experience. First, there is the role of memory, which is also processed in the limbic system, primarily in the hippocampus and amygdala. Our memories of pain and associated causes of pain are essential and life-preserving because we need to remember what caused us pain to avoid further injury or death. There are other important cognitive activities that influence pain experiences, like controlling behavior and decision-making, which are part of the executive functions and occur in the frontal lobes. When you combine the emotional components of fear and anxiety together with cognitive activities, the brain can drive the experience of pain itself, sending signals through the descending pathway. How does this happen? One way, for example, is through the influence of fear, anticipatory anxiety, and memory on the catastrophization around pain sensations and around activities that can cause pain. What is catastrophization? Catastrophization is an irrational thought a lot of us have in believing that something is far worse than it actually is. When there is catastrophization of the pain sensation itself, this reflects fearing the worst about what the sensation is going to feel like. Pain researchers have shown that when you create conditions where people fear the worst about an upcoming stimulus, they will experience pain even when the stimulus objectively is not painful. When there is catastrophization about activities, this reflects believing that doing something is going to be worse than it ends up being, such as fearing that doing a load of laundry is going to cause a lot of back pain, which will worsen injury, then eventually cause disability, and perhaps even lead to loss of function or paralysis. For people with chronic pain, you can see how catastrophization about pain sensations and about activities can cause a cycle of pain and disability, loss of function, and quality of life. Another way in which the brain is a driver of pain experience is through our culture. Our upbringing and social values are major components of our culture, and they influence how we express pain and suffering through our thoughts and behaviors. Some cultures tend to encourage the expression of pain, such as those in the Southern Mediterranean and Middle East. Others suppress it, such as tends to happen in American and German cultures. This is shown in the many lessons to our children about behaving bravely and not crying. In cultures of Southeast Asia, there's a tendency for people to keep their pain to themselves. You likely have seen different expressions of pain in your patients who come from different cultures. What these cultural differences tell us is that there is a learning component to the experience and expression of pain. And so this is another example of the brain's influence on pain. Now that we've examined the role of the brain in mechanisms of pain, let's turn now to the role of adverse childhood experiences, or ACEs, and trauma in pain. You may already be familiar with the term ACEs, which came from the seminal study conducted in the mid-1990s by doctors Vincent Felitti and Robert Anda with the CDC. ACEs are 10 categories of childhood maltreatment and household dysfunction. The original study and subsequent extensive research has shown that ACEs are risk factors for the major sources of disease and disability. ACEs are common in Oklahoma, the United States, and worldwide, and they have tremendous impact on the lifelong trajectory of physical health, mental health, and other social, educational, and economic outcomes. When ACEs can be buffered by a protective environment, such as a supportive parent or caregiver, they pose much less risk to health and social outcomes. However, in the absence of a protective environment, they can be traumatic and are considered to be toxic forms of stress. Research shows that ACEs are associated with impaired development in critical areas, such as the brain, the immune system, and pain mechanisms. ACEs are one potential source of toxic stress and trauma. There are many different sources of trauma, some of which are illustrated here. Trauma is considered to be the emotional or psychological experience when there is serious adversity or terror. A really crucial point is that ACEs and trauma are highly associated with pain conditions, such as chronic back pain, IBS, and worsened pain outcomes. ACEs and trauma also change how the brain responds to pain. Let's take a look at this a little more deeply. ACEs and trauma pathways in the brain overlap greatly with the pain pathways shown here. Traumatic stress responses occur in the limbic system, such as the hypothalamus, amygdala, and hippocampus. The frontal lobes, where critical cognitive activities occur, are developmentally impacted by ACEs and are hijacked or derailed under conditions of acute traumatic stress and trauma triggers. Repeated exposure to stressful and traumatic events activates brain pathways involved in the processing of physical pain. Incoming pain signals are amplified in the brain. Over time, the brain establishes strong pathways which heighten pain signals. An important research finding is that the brain can perceive pain even when it is not proportional to damage or injury. In other words, the brain becomes more sensitive to pain signals, like an amplifier on an electric guitar set for a concert arena rather than for the garage. I want to be clear about the following. This does not mean that the pain is all in your patient's head, made up, or imaginary. The process I am describing is amplification, not imagination. The stress response begins with the activation of the autonomic nervous system, in particular the sympathetic nervous system, with symptoms being pretty instantaneous. The stress response is also comprised of stress hormone pathways, which are interconnected and coordinated with the autonomic nervous system. Next, we will take a closer look at the hormonal stress response because of its important intersection with pain. We are familiar with the sympathetic nervous system mediated physical reactions of pounding heart, rapid breathing, muscle tension, and so on. The hypothalamic pituitary adrenal axis, or HPA axis, integrates and mediates this response. The perception of real and/or presumed physical and social threats causes activation of the HPA axis. The stress response begins in the limbic system, in the amygdala, which stimulates the hypothalamus to send a hormone to the anterior pituitary gland, which in turn sends a different hormone to the adrenal cortex, which then releases cortisol in the body. So, the stress response begins with discharges in the brainstem, which act to release the stress hormone cortisol that increases pulse, blood pressure, and inflammation. Under conditions of chronic stress, the HPA axis is activated repeatedly, with more cortisol circulating through the body. The HPA axis is able to make memories and associations based on its activation. This sets the neurobiological stage for introducing ACEs and trauma's impact on brain pathways, memory, and amplification of the stress response. When stress is strong, frequent, and/or prolonged in early life, such as through ACEs without adequate adult support, a toxic stress response occurs. Toxic stress is a prolonged activation of the stress response system shown here and can disrupt the development of brain architecture and other organ systems in children and increases the risk for stress-related disease and cognitive impairment into the adult years. How does this relate to pain? In chronic pain, a similar mechanism occurs. The HPA axis is activated repeatedly in periods of chronic pain, just as in periods of chronic stress. The HPA axis isn't able to shut itself off and runs for longer amounts of time, with the system continuing to produce stress hormones, lengthening and enhancing the stress response. The HPA axis is also implicated in the amplification of pain because of its ability to make memories and associations based on its activation by pain stimuli. So, As clinicians, we need to shift our understanding of pain and recognize the central role that the brain plays in driving the perception and experience of pain. We also need to recognize how ACEs, toxic stress, and trauma can sensitize the brain to pain. And because of this, what we need is a new approach to pain. What we do know, and you know this as a clinician, is that opioids are not effective in the long run. What we also know is that we have a collection of evidence-based, non-pharmacological interventions for pain, stress, and trauma. And they hit all of those different areas around which pain and stress operate, which are sensory, emotional, cognitive, and behavioral. These non-pharmacological interventions influence and change the brain areas and pathways involved in pain and can downregulate the experience of pain. For example, cognitive behavioral therapy can target unhelpful thoughts like pain catastrophization. Mind-body skills can interrupt and calm physiological responses to pain, stress, and trauma triggers. A number of behaviors can also lead to endogenous endorphin release, such as listening to music, meditation, and laughter. Upcoming, my colleagues will take a closer look at these non-pharmacological interventions, but some ways in which you and your staff can get involved is to educate your patients about how the brain, stress, and trauma affect pain, educate them about services, and refer them for treatment. Here are some key points to share with your patients. First, the brain and pain. Pain signals from the body turn on brain responses that are recognized as a sensation. Pain signals from the body turn on brain responses that recognize a sensation as pain, but also emotional responses like worry, or thoughts like believing the worst about a painful situation, or behaviors like avoiding doing important things that could be done with some adjustments. The brain sends signals down to the body about pain experiences and can amplify the sensation of pain, especially when there's been stress, ACEs, or trauma. This is like turning up the volume on a phone. The signal coming to the phone is the same, but the sound will be louder when the volume setting goes up. Stress, ACEs, and trauma can set the volume higher. Non-pharmacological interventions for pain can turn the volume down. These interventions work along the neurological and hormonal pathways and centers to turn volume down through endorphins. These interventions can hit all of those different areas around which pain operates, like sensations, emotions, thoughts, and behaviors. Thank you for your attention. My colleagues will next take a more detailed look at non-pharmacological interventions. I encourage you to take a look at the resources we've provided for more information. Dr. Jolly, I'll turn it back over to you.
Thank you, Fran. Now I'd like to tell you about another patient, but I need to give you some background first. My focus after residency was preventive medicine. I went to Colorado to do a preventive medicine fellowship, got a master's in public health, and was working on behavior change in primary care. This was in the late 1980s, and much work was being done on prevention. The United States Preventive Services Task Force had come into being, smoking cessation aids were available, the executive physical was all the rage. Yet as I continued in my career in primary care, there were a lot of disappointments. So few people actually did the things we told them to do. We knew how to help them, but patients just didn't do it. What was wrong with them? So let's fast forward 15 years. I had the opportunity to hear a speaker at a conference here in Tulsa in 2007. That speaker was Dr. Vincent Felitti, who was one of the lead investigators for the Adverse Childhood Experiences, or ACEs study. Dr. Wen mentioned that study earlier. Dr. Felitti is a general internist who had been working in preventive care and obesity treatment at Kaiser Permanente in California. Taking comprehensive histories from some of his patients who failed the program, he discovered what he thought initially were just a handful of adults with significant childhood adversity or trauma. The large ACE study showed him it was not a handful, it was many, many patients, like the ones we see every day. Soon after that, I came across a patient in our resident clinic who I'll call Melissa. Melissa was 34, morbidly obese, smoked, had out-of-control diabetes, and already carried a diagnosis of COPD. While reading her chart after seeing her with a resident physician, I found this in her social history. and I quote, "Molested at age 8, raped at 13, grew up in a home with alcoholism, instability, and physical abuse." Melissa had been to the psychiatry clinic and they took a much better history than we had. I thought at the time, oh, wow, I have found one of them, one of these patients that Dr. Felice had told me about. I know now that these patients were all around me, and I just didn't realize it. I hadn't asked or understood how trauma can affect people's health, their pain, or their ability to make changes. This realization made me rethink many of the approaches I'd taken in preventive medicine and chronic disease. Melissa had not been able to quit smoking, lose weight, control her diabetes, or try new approaches, despite the best efforts of her primary care provider. Because of the toxic stress Melissa had endured in her childhood, her brain may not have been ready to make changes. Her problems were solutions for Melissa that helped her manage her stress. Following my introduction to Melissa, I found many more patients who were a lot like her. Multiple problems, multiple medications, little progress. I saw the pattern in both women and men, older and younger patients. I didn't always know the stories. Sometimes patients want to tell you, other times they just want you to know that their lives have been hard, but don't offer details. Let's talk more about how trauma and toxic stress can affect one's ability to take action for change. So we typically think about these kind of things when we're giving behavioral intervention advice to our patients. Eat healthy, lose weight, exercise, stop smoking. Next slide. But now we understand more about how past toxic stress and trauma can sabotage these efforts. We need to consider a different approach to helping people. The ACE study pyramid, next slide, is one way to describe the mechanisms through which ACE influence health and well-being throughout one's life, with disrupted neurodevelopment leading to social, emotional, and cognitive impairment, high-risk behaviors, and poor outcomes. On the next slide, you can see that traditional interventions focus higher up on the ACE pyramid. Stressed adults who have experienced trauma in past and current life may not respond well to educational and behavioral interventions. These interventions are needed, but the preparatory interventions are likely needed first. You could see this in this animation. All right, next slide. The good news is that these preparatory interventions can be both methods for preparing the brain for change and treatments for chronic pain. Next slide. These activities can help reduce stress hormones, engage the vagus nerve and the parasympathetic nervous system while reducing inflammation, helping the body return to that normal idle speed most of the time rather than always living in red alert mode. They can help reverse toxic stress physiology. These activities can also help with patients' executive functioning skills, engaging the thinking part of the brain to help follow through with behavior change. Next slide. So what can you do? Here's some of the things that to start thinking about. I'm going to let Dr. Kim Kuhn tell you more about what I want to stress, but what I want to stress is that these things do not need to be done all in the same visit, but may be done in small pieces in consecutive visits, and the approach will vary from patient to patient. Much of this is about building the relationship with your patient, helping both of you understand what may be holding them back. So Dr. Kim Kuhn from the Department of Psychiatry is here to tell you more about these interventions. Dr. Kuhn?
Thank you, Marty. So over the next few minutes, I'll be sharing information about the therapies and strategies that have potential to help target your patient's chronic pain and distress. These ideas are not intended to be all-encompassing. These strategies were selected specifically to activate the various brain structures that Dr. Wen talked briefly about that will allow your patients to get better and then maintain those treatment gains. As we review these options, I suggest that you try some of these strategies or apps before recommending them to your patients so you're able to speak to the specific benefits. Also, be sure to brainstorm with your patients to gather their ideas for coping and improvements in well-being by asking, what did you used to do to feel better and cope before your chronic pain began? Next. First, let's review some basic interventions that lead to long-term reductions on toxic stress hormones and decrease pain symptoms. For example, simple movements and activities like walking or dancing can downregulate stress hormones and reduce inflammation while enhancing neuroplasticity. Also, using simple hygiene techniques can improve sleep, building your patient's immune system. Mindfulness meditation counteracts toxic stress as well. Many researchers promote a dietary approach to help reduce chronic inflammation by cutting out processed foods and adopting more of the anti-inflammatory foods found in the Mediterranean diet. Next, let's review a high-value formal treatment, CBT, which has been proven through over 400 randomized clinical control trials to create positive changes in the way the brain builds new and helpful connections. CBT is actually an umbrella term for a variety of approaches that help patients access the prefrontal cortex to activate those higher level brain functions such as emotional regulation, healthy decision-making, and predicting consequences of current behaviors. CBT is especially helpful if your patient's brain has been hijacked by the limbic system from either ACEs or other traumas. During treatment, therapists help their patients identify negative or unhelpful thought patterns and behaviors, and then uses design methods to teach their patients to examine these unhelpful habits in order to disrupt dysfunctional repetition while learning more realistic approaches to their brain and body health. Successful treatment with CBT leads to measurable changes in brain connections. Neuroplasticity occurs from new learning, leading to new thinking and new behaviors. CBT actually changes both the brain's physical structures and functional organization from top to bottom. When the new learning and behaviors are practiced, more functional brain connections are continually strengthened and expanded. The new healthy thinking and practical behavior changes resulting from this remodeling can remove the barriers to doing paced physical activities such as dancing, walking, or swimming that lead to lower chronic pain symptoms and improved overall well-being. Remind your patients that these changes will take some time, so encourage them to give treatments a chance. Explain that these changes will not feel right initially because they are trying out something new, so daily practice with their therapist will make it easier and more natural over time. Now, let's take a look at some of the researched activities that patients can do to feel better. As you can see from this brain scan pictorial, a simple walk can boost the brain's feel-good hormones. Again, these are not the only strategies your patients can try. These strategies were selected because of the evidence base supporting their helpfulness. Tai Chi is often described as a meditation in motion, but it may as well be called medication in motion. This strategy uses low impact, slow motion exercise where the patient breathes deeply and naturally with focused attention on body sensation. Movements are circular and muscles are relaxed rather than tensed. The joints are not fully extended or bent, and connective tissues are not stretched. So Tai Chi can be easily adapted for people confined to wheelchairs or recovering from surgery. Deep breathing is a free and portable way to stimulate one of the most important nerves in the body, the vagus nerve. As Dr. Friend mentioned earlier, it stimulates that sympathetic parasympathetic nervous system. Deep breathing does require much practice to create muscle memory to use in real time when pain increases and your patient is under duress. Here are some apps that your patient can use to learn and practice at home. I recommend the Breathe to Relax app as an introduction to the benefits of using breath to reduce distress and pain. In practice, I advise patients to practice for 10 minutes daily, 5 minutes in the morning to begin their day, and 5 minutes at bedtime to improve their sleep. Mindfulness is a great skill for your patients to learn and use for coping with both pain and associated mood and anxiety symptoms. It is especially helpful for reducing the fight, flight, freeze symptoms while encouraging focus on being in the present. This strategy is a proven brain changer. Much like Tai Chi and meditation, breath-focused yoga changes the brain's valuable positive neurotransmitters, such as dopamine, oxytocin, serotonin, and endorphins to improve your patient's sense of well-being while reducing those stress hormones and inflammation. There are some apps that you can recommend for your patients to try to track their pain symptoms, such as their intensity, frequency, and duration. This can be useful for your patients who endorse their chronic pain symptoms in a Gestalt fashion rather than reporting to you their specifics. This can be very helpful for you to measure improvements or pain triggers. Finally, here are some suggestions for books that your patients can use who have reported ACEs or childhood traumas. Donna Jackson Nakazawa's book, Childhood Disrupted, connects the dots between childhood trauma and the physical and mental suffering so many of your patients live with as adults. The first few chapters cover the science of trauma, and later chapters offer solutions for building resilience. The Deepest Well is written by the current Surgeon General of California, Dr. Nadine Burke Harris, who has committed her career as a pediatrician to helping children and their families with various types of household and environmental trauma. The book Courage to Heal is specifically for patients who have a history of sexual abuse, and it has an accompanying workbook. Finally, be prepared to reassure when you refer. Oftentimes, when you refer a patient for psychotherapy, it can feel invalidating for a patient because they often hear that it's all in your mind when you suggest that they come for therapy. So be ready to regulate their responses and remind them that you're referring them because you want a more comprehensive way to deal with their pain, that learning about how their brain is involved in their pain sensations can really make a difference, and you can be ready to provide that rationale and then help your patients understand or feel understood and ensure that you set up realistic expectations for improvements and outcomes. Now I'll turn things back to my colleagues to explain more about what you can do to help your patients with their chronic pain.
Thank you, Kim. I hope that you now have a better idea of what these therapies are and how to briefly explain them to your patients. I want to tell you about one more patient of mine. Donna was a 56-year-old woman who came to me from another primary care doctor about 6 years ago. She was also seeing pain management and had tried various opioids and injections for her chronic low back pain. She was frustrated because she didn't feel these really helped her that much, and she had side effects with the opioids. She worked at a child care center. Her pain was really affecting her ability to do her work. After several visits, she felt more comfortable talking to me about her life and her family. She had lost her mother at a young age and hinted at a lot of hardship in her younger years. She was caring for her son's toddler. Her son was in prison and was a single father. We talked about her stress and how that could contribute to her pain. At first, Donna was skeptical because this was not how she thought about pain in the past. I gave her some options for reducing stress, and she considered these over several weeks. She had a friend who did water exercise at the Y, and that was close to her, and she decided to give it a try. She discovered both a friend group and an exercise that helped with her back pain. She was able to do this because her grandson could come with her to the childcare there. It was good for both of them. She had some visits with our in-house counselor to help her discover ways to manage her stress using CBT and other tools. Donna still has some back pain, but she's not taking opioids, she's healthier, and she's able to do her job. When the pool closed recently due to the pandemic, she was devastated. I know she'll be back as soon as it's safe. Does every patient respond like this? No. But we've discovered that using an approach that recognizes how trauma affects their symptoms, a trauma-informed approach, can help many patients be more successful. Dr. Miller-Cribbs will now tell you more about this approach to patient care using the trauma-informed approach.
Thanks, Marty. So I want to start today by, can I have the next slide, please, Dan? to talk to you about what trauma-informed care is, what it means, and why it's important for Oklahoma. I'm going to give you a little bit of Oklahoma context that relates to trauma in our state and why it's important to think about it in all primary cares in Oklahoma. And then I'm going to talk to you about the elements of trauma-informed care, and then a little bit about what trauma triggers are and how to address them and think about employing trauma-informed care practices into your practices. So when I think about the Oklahoma context, there's lots of things, but some things that really stand out are these particular events on the slide. The first is that Oklahoma was the end site of the historic Trail of Tears, where thousands of Native Americans died along the way and then ended up in Oklahoma. If we think about Oklahoma health outcomes to this day, we can see pretty dramatic health disparities among our Native populations in Oklahoma. The second issue is that Tulsa, Oklahoma specifically, was the site of the worst massacres in the history of the United States. We're actually approaching the 100th anniversary. We just passed the 99th anniversary of this event, and it continues now in current times to even become a more salient and important event that we need to think about, and how it still lives in literally our DNA and in our culture and our society to this day. And when you think about health disparities that exist in North and South Tulsa, you can see this legacy not only through this event, but through historic and systematic racism and oppression over time. We also a lot of Oklahomans were a part of the Dust Bowl, which was a really difficult time for poor farmers. And many of them suffered great financial crisis and drought, and eventually left Oklahoma to California to try to find a better life for themselves. We also have difficult weather in Oklahoma, as you know. It used to just be tornadoes, but now it's also earthquakes. But this kind of event happens a lot and frequently, and what we know is that people that experience trauma often experience traumatic like events such as tornadoes, even in a more dramatic fashion. We also were the site of one of the worst domestic terrorism acts in the United States, and with the Murrah bombing. And as you all know, that definitely lives in the DNA of Oklahomans and is a salient traumatic event for many, many people. Then last but not least, we incarcerate more women than anywhere else in the country and in the world. And we actually incarcerate more men too than anyone else in the world. And I just recently learned also that in Oklahoma, you are 8 times more likely to be shot if you're a Black person than you are if you live in the state of Georgia. So there's dramatic disparities that exist in our criminal justice system that need to be addressed. And when you think about the fact that one of the ACEs scores is having a family member or caregiver in prison, we already know that means that Oklahomans are going to be starting with a higher than average level of ACEs. And then on top of it all, we're in the middle of a global pandemic, and people are wearing masks and people are getting swabbed, and it's scary and frightening. And when I think about people who are already experiencing trauma, and then you layer this on top of that, it means that we are in a situation where a lot of us are feeling vulnerable and isolated and alone and afraid, and that's even more prominent for those people experiencing trauma. So this is a slide that conceptualizes, I think, nicely the main 5 characteristics of what we call trauma-informed care: safety, choice, collaboration, trustworthiness, and empowerment. And what this means is that these are the elements that if you want to try to create a trauma-informed agency or a trauma-informed primary care facility, you want to try to think about how you move toward these concepts. How do you make sure people feel safe? How do you make sure people have as much choice and control as they can have in your setting? How do you ensure that people and those relationships with people are collaborative, and that there's information sharing and power sharing between those people being served and those serving? How do you make sure it's trustworthy, that people feel respected and that the boundaries are clear and maintained? And how do you make sure that the environment feels empowering, that you're not just doing for, you're doing with, and that people feel like they're gaining skills and getting better at things over time after interacting with your practice? So when we think about traumatic events, we've been talking about that some today, ACEs, and Dr. Nguyen touched on that. But what are traumatic life experiences? Well, there can be a whole bunch of different kinds of categories of trauma. The most obvious are physical, emotional, or sexual abuse trauma, both in adulthood and in childhood, rape and sexual assault, but also things like serious medical illnesses or disease. There's a literature about how children who experience serious or chronic diseases can sometimes experience trauma as a result of that. Family dysfunction and disruption, which we have talked about in terms of substance abuse, homelessness, disruption by prison, catastrophic events, and this can be something like we talked about with weather or the bombings, but it also can be, losing your home, losing your job, going through a pandemic like we are now, and then also involved in or witnessing horrific events. Witnessing violence can also be extremely traumatic, particularly for children who have a difficult time kind of separating out that this is happening to someone versus happening to themselves. So a trigger to a trauma, what do we mean by this? And I'd like to start this conversation by saying sometimes when we're in day-to-day practice in our lives, we see people kind of overreact to things, or at least in our minds, they seem like they're overreacting. And this is because sometimes people who have experienced trauma may behave in ways where it's difficult for the person to understand who's watching it from the outside unless they're taking the perspective of the person from the inside, because they may seem out of whack or exaggerated with our reality. But often what's happening there is that a person is been triggered, and so they are experiencing the feelings or the symptoms of the traumatic event as if they experienced it in the past. And it can be a physical reaction such as racing heartbeat, sweating, pain, fear, and it can also be an internal one where people are just feeling the emotions and the anxiety and the panic that they felt when the trauma happened to them. And so this trigger, why this happens is because this trigger reminds the person of the original trauma. And this is an important concept to understand, because having control of that trauma trigger or having control of that reaction is going to be a key to health and well-being. So let's say, for example, a trigger may be that you spill your coffee on your shirt while you're in a hurry in the AM. And it triggers this feeling of, oh, I never get anything right. I'm going to get fired. All these things. And so you have an uncontrolled or reactive response. And the result may be that you yell at your kids, you grump at your partner, and you can't find your keys. Whereas if we can control those reactions, such as a trigger like you spill coffee on your shirt while you're hurrying in the morning, and you can get yourself centered and have a controlled response through the many ways that Dr. Kuhn has talked about, you can have emotional control, you can concentrate, your memory's okay, you can find your keys, and you can take thoughtful actions. Now this takes practice, right, and control, and learning this through role modeling and a whole host of other positive things across your life. But if, in the next slide with the examples, is if you have experienced previous trauma, sometimes these responses that you get can be very uncontrolled and reactive and out of whack. So say, for example, you had a severe dog attack as a child and a little tiny chihuahua runs up to you to say hello. It triggers you and you think, oh my gosh, I'm going to get beaten. I'm going to have to get stitches. I'm going to have to go to the emergency room again. And so your uncontrolled reactive response to that trigger is to scream, kick the dog, run away, fight, freeze, and flee, whatever it is, right? Or another example is you had past military service in combat that was very difficult, and you're at a parade and you hear fireworks and loud banging noises, And your uncontrolled response is to take cover, to freeze, to have anxiety, to get fearful, to be defensive, or to sometimes fight. And so what we want to do is help people think through and help all these interventions that Fran and everybody have talked about so far is about trying to figure out how to help people control those reactive responses. Get them out of freeze, flight, and fear and into a place of control and good executive functioning. Okay, Dan, thanks. So what I think about when I'm thinking about primary care is you may think to yourself, well, we don't have fireworks or dogs in primary care, so what's so traumatic about that? And so I would sort of challenge us to all think through the standard procedures that might trigger traumatized patients in a primary care setting, what those might be. Well, for one, any procedures that feel invasive, right, to a patient may feel like an assault. Something as simple as a swab to the throat could really initiate an interaction in someone that was sexually assaulted. The thyroid example is one of the classic examples that we talk about, where you come from behind somebody and you're not making eye contact and it feels a lot like strangulation, or could to someone who's experienced that. But the increased vulnerability, the personal questions, the need to disrobe yourselves in primary care, these are all potential triggers. They're normative elements of a medical visit, but they're also potentially problematic if people are not primed, warned, or feel safe. The vulnerable physical position and physical touch is another issue. Touching and examining sensitive body parts, lying down, being probed, even injections. And in addition to smells in the office, sometimes alcohol, for example, is a strong smell in a medical setting, and that could be triggering to some patients as well. So what do you do? So the next slide, oh, sorry, forgot about the slide. The first thing we need to do, and this is to repeat what Dr. Wynn already mentioned, which is making that shift from what is wrong with you to what happened to you. And this helps us then not see reactions as out of whack or triggers as weird. Instead, it helps us put ourselves in the shoes of the person who's experiencing that trauma and who has been triggered. And that helps us understand better how to intervene with that person. So what can you do? Here are some things that I'm going to briefly talk about really quickly that you could easily do in practice that could help. The first one is to go low and slow. Trauma, as you know, next slide, Dan, please, is loud and violent and big and scary. And so oftentimes when patients are excitable and very agitated, lowering your tone, talking slowly and respectfully can sometimes help, because you are staying calm and in control, and you seem like you're providing sort of a box or a circle of support around a person who is feeling very, very out of control. And so when you go slower, and we say lower when we're working with children, because often too, if you're up here and a kid's down here, if you can get on someone's level, that often helps de-escalate a trigger as well. So go low, go slow, go softer, right? And that's hard to do when someone's real agitated and getting on your nerves, but it's often very important to think if you want to try to de-escalate. And anything that you can do when you can get people to engage this part of their brain, right, the thinking part of their brains, asking a question that makes them engage their brain, that moves them from this emotional state quickly or more quickly to this part of their brain, and is just going to automatically start calming them down a little bit, because you can't be thinking about things and both highly emotional at the same time. The next slide is about being respectful and professional, and these are pretty easy things to do, but they're often sometimes overlooked. Asking for permission for touching patients, or telling them what you're about to do, really can help lower their anxiety. You're going to say, this may feel cold, or I'm going to do this. And even though those seem like little small things, to someone who's experienced trauma, these are very helpful moments. I like to call them in social work priming. You're priming somebody for what you're about to do. And just like paint, right? Your coat of prime helps your paint stay on better. When you prime a patient to get ready for something, it often can help it go better. The other thing to think about is language and the words that you use. Use very simple language that's not confusing or overwhelming. And then we talk about using professional language. In particular, try to avoid anything with a sexual connotation. So instead of, your or but or bed, say the bottom or the exam table. So say hop up, instead of saying hop up on the bed, say, could you please get on the exam table? That just sounds a little bit better to somebody who may have sexual abuse, for example. I've talked about predicting, priming, and preparing, and breaking down the steps. Mentioning each step before you do it is very helpful. And also maybe just say to patients, okay, so what have you done before when you feel stressed, if you're about to do maybe a procedure that's causing them anxiety? Could we do that? Have you tried deep breathing? And if they say yes, they say, okay, well, how about we try some deep breathing right now while we do this procedure? You want to try it for me a couple times? And then you move forward with the procedure. Because the other thing is that you're also role modeling some good skills for them in the practice itself with the patient who may experience trauma. And obviously doing the good things that all good physicians should do about validating feelings and encouraging behavioral changes when you observe them are also good things to do. And then last but not least is offering choice and control as much as possible. This is interesting concept because sometimes in primary care there's things we have to do to patients. So what are some things though that we could offer some choice and control that would make them feel better? Well, one is instead of just you shifting their clothing, ask them to shift it for you. Or ask them about an exam. If there's another way to do something or two ways to do something, say, well, we could do it this way or we could do it this way. Just the littlest thing can make a person feel more in control if they feel empowered or as if they've had some choice. Also being as efficient as you can be, obviously not rushing, but being as efficient as you can so that you can not make patients uncomfortable for as the shortest amount of period as is good. So checking in and frequently and communicating is very important, and also calling out when you notice something. So if you notice a patient is anxious, say, you seem anxious. Is there something that you should want to tell me about that you're uncomfortable with? And then that way you know what's going on, and then you could talk to the patient about that. Or do you have difficulty when someone touches your knee? And then they might tell you what's going on. Or I really noticed that you seem very tense. Is there something that I should need to know? Or is there something that I could do to help you feel less tense? The ultimate goal for a primary care visit is then a safe, comfortable experience for all of your patients, including those with histories of trauma. And so if you can establish trust and reinforce care and reduce exposure to shame and vulnerability, you're going to be able to achieve that. Then the last thing I will say is, as you're thinking about how you might incorporate some of these elements in primary care, there's some excellent resources online. There's checklists and all kinds of articles that talk about how to make a practice or an agency trauma informed. One of the first things that you can do is to think through a typical office visit through the eyes of someone who's experienced trauma. What does it look like in your waiting room? What is triage like? What is the check-in process like? And how might, if this is a person who's experienced the trauma, see the environment? Think through universal precautions, for example. We don't have to do, or at least I'm told, I'm not a medical doctor, but I'm told we do not have to do thyroid exams from behind people. We can do them on the side or from the front, making eye contact. So thinking through universal things that we normally do that might be things that we can do differently that would then be universally better for everybody, including traumatized patients, are good ideas. thinking about how we re-traumatize and triggering trauma and how we can avoid doing that, either through priming, like I talked about, preparing and being clear in our communication, training staff and everyone for experiencing trauma and some of the skills and making those shifts from what's wrong to what happened, and some basic de-escalation and empathy training for those people experiencing trauma is also a good idea. And then creating a safe and open environment. You know, if you have materials in your waiting room that have resources for people experiencing trauma, that in and of itself tells patients, oh, they're open to this, or, oh, I could talk about this, or I could bring this up if that's a problem. And so having posters and literature and other articles and whatever around the waiting room, just that address trauma generally, say to patients something powerful, which is, this is a place that's safe for you to talk about these issues. Okay, I think that's everything. Thank you.
Thank you very much, Julie. There's a comment in the chat that basically says there are studies that assess the efficiency of combined CBT and pharmacologic interventions versus CBT alone. This person's clinical inclination is there a 1 + 1 = 3 effect, but I'm not sure if this is evidence-based. Kim or others, how would you address this question, this issue?
I personally can't speak to this in terms of pain, but in terms of mood and anxiety disorders, when they look at CBT alone for mood and anxiety, you reach a 50–60% response rate for, let's say, mild to moderate depression, and the same for antidepressants. When you combine the two with competent CBT, you jump into the 85% response rate. So what they find is medications act first, bottom up, and CBT acts top down and maintains treatment gains. So I don't know if it equals 3, but it gets way up there in terms of maintaining treatment gains and preventing relapse and keeping people well longer. And oftentimes they don't go off medications as quickly.
Thank you very much, Kim. There's a question in the chat that asks, should primary care practices screen all of their patients for ACEs? Marty, do you want to head off that one off?
Yeah, I'll address that first. That is a big question, and there's a national debate going on about that right now. Some of you may have heard about what they're doing in California. Davey Burke-Harris is the Surgeon General of California and is a big proponent of ACEs screening, especially at the pediatric level, but they've kind of expanded that to adults. It was actually just an article or an opinion piece in JAMA last week from a family physician who was actually countering the idea that we should be screening for ACEs in primary care. I think our general approach in our group, and I'll let others speak for themselves, but is just handing a person an ACE screen with the 10 questions that were originally developed to be used in research. They were actually not developed to be used clinically, and not preparing the clinic, preparing the clinicians, preparing the patients, and being ready to respond to that is definitely the wrong thing to do. And I'm afraid that in a rush to address the ACEs problem in our country, that is actually what I've heard some clinics have done. And I think what we like to do is advocate for a more case-finding approach, which might be, those 3 patients that I told you about today, or many, many others. If they're having difficulties, you're having difficulties, there's something that says, you know what, I want to know more about what might be going on with this patient, then screening in the relationship, in a discussion, if it feels comfortable for you to give somebody a screener, a questionnaire, I think that's okay. We personally don't do that in our practice. We usually just ask more general questions and don't focus on the number. You know, a score of 4 is not equivalent in clinical practice. Someone, depending on their protective factors, depending on how severe the exposures are. So we right now don't recommend just making sure that everybody gets a piece of paper. We really want to do more of a trauma-informed approach and do the screening within the doctor-patient or the clinician-patient relationship. And I don't know if any of my colleagues want to add to that or not.
So if there's no comment to that, let me ask you a question, Dr. Nguyen. You've been teaching the physicians for some time now the use of these modalities in treating patients with pain and trauma. What kind of resistance or difficulties do you see that clinicians have in accepting the science that you have presented and implementing it in their practices?
Thank you for the question, Dan. So yes, we've been together as a group, been working with our interns and seniors, the second and third year residents in internal medicine and family medicine, using a simulation-based approach, which also incorporates didactics like we provided today, as well as a video example of what an encounter might look like when a clinician speaks with an adult patient around their ACEs history. And let me preface my next comments with saying that we've really focused on working in primary care with clinicians that work with adults, because our colleagues in pediatrics are doing amazing work with that population. So we really sought to fill the gap in that area and working with adults. Yeah, we do occasionally get resistance. I think a lot of it is not so much the science. I think people understand the science and actually crave more science from us. It really has to do with how this will change the encounter, and will this prolong the 15-minute unit of care that people have, particularly when they are dealing with so many other conditions because of the multimorbidity that people address in adults who are affected by ACEs. So the argument that we make, and I really obtained this from a colleague of mine at the University of Buffalo. He's a chair emeritus there, and when I presented at a international primary care conference about the work that we were doing, he came forward and said, I've been doing this since I was a rural family doc, and I've been enhancing my work in this as an academic. His argument is that people are afraid of Pandora's box, right? Opening up Pandora's box. His argument is that Pandora's box is already open. You can see that in the long medication list. You can see that by people's attempts, or maybe the yes butters around behavior change. So there may be a lot of people who make good faith efforts and a lot of people who will say yes but. So there are different forms in which people are not successful at behavior change. Also just the clinician's response when you see somebody's name on a schedule, and because of the nature of the interaction, there may be a sort of a visceral response. Also the heightened use of opioid medications for what may a clinician may perceive to be more emotional responsivity. He says that in his experience, and we've been teaching our residents and their feedback, especially those that have gone into practice, is that it actually has helped them. That Pandora's box is open, but the skill set helps them. By the way, does anybody know, once Pandora opened up the box and let chaos into the universe, what was at the bottom of her box? Does anybody know? What was left behind? It was hope.
It didn't escape then, right, Fran?
Yeah.
So Kim, let's thank you very much for that information, Fran. That was really terrific. Kim, let me ask you a question. You are on the receiving end of patients being referred from primary care practices for cognitive behavioral therapy. And we have this sense that in primary care that patients are not very receptive to getting that referral, and you spoke about that in your words. Can you comment further on that? Is it a matter that we in primary care just aren't convinced that CBT has value, and therefore are unable to help our patients understand that, or is it patient resistance and it's not worth the time and effort?
I think it may be more in the messaging. I think sometimes when physicians make the referral, it's the throw up your hands. I don't know what to do with you, so I'm going to send you on because you're frustrating me. And so the messaging gets lost in that. Other times they know it's going to be helpful, but they don't know quite how it could possibly be helpful. And then there's the fear of the patient that, oh, you're referring me, you must not be taking me seriously anymore. You think it's all in my head. So it's a multitude of factors. So I think if the physician can explain some of in simple terms, how the brain is involved and how therapy can make some of those brain changes to assist with the other changes that they're going to recommend, it can really facilitate the patient really engaging in treatment and understanding how these little changes can make such a difference in all of it. If the physician says, you know, I'm going to refer you for something that we know is a proven brain changer, and this is going to make a difference. It's not just, you know, I'm going to refer you over there so they can, you know, change the way you think about pain. It's going to be a brain changer. It could make a big difference in how the patient approaches it. I often have patients come in and they're very well defended. They're a bit like this when they come in with their arms crossed. My doctor thinks I'm crazy and I don't know why I'm here. And it takes about 10 or 15 minutes to talk them back down again into, no, it's not that you're crazy, and it is all in your head because that's where your brain is. But that doesn't mean it's imaginary. As Dr. Wen said, it just means that your brain's in charge, and we have to get your brain in a different place in terms of what's really running the show. Is it going to be your limbic system and your past traumas, or some of the fear-based thinking that's going on, or is it going to be a more a different approach to handling your pain, and how can we keep you moving? For example, you know, people hear you say you need to exercise, and they're thinking, right, I'm going to get dressed and go exercise. You're like, no, what if we try something called exercise in bed, where every day when you wake up, you're going to be doing some stretching, and you're going to be doing some water bottles, and you're going to be doing some things like that. And they're like, oh, it's just a completely different way of thinking about exercise.
Thank you, Kim. That's really very, very helpful. Julie, you're in the business of training our really very important social workers who do a lot of counseling. And I'm grateful to say that in Oklahoma, thanks to the primary care initiatives, that we are increasingly embedding social workers, counseling social workers and psychologists in primary care practices so that we can have a warm handoff for patients who can benefit from this kind of training in brain modification. How are the students that you're working with, and how are the practicums going in this new use of counseling?
I think they're going fairly well. I think when you start something like this and you're kind of putting social workers into some different roles. I mean, historically, social workers in medical practices have been resource providers, which is, you know, still something that they do, but that's also social workers have skills beyond that, which could include, you know, doing some of the therapies such as Kim described, you know, and or more advanced treatment. So as we get better and have funding mechanisms that support the role of social workers and other healthcare mental health and behavioral health providers and practices, I think the better that we are going to get at this. I think one of the keys about integration into primary care is that people don't leave. Like if Marty or you or says something to a patient like, I really think you've had this history of trauma and it sounds like you might benefit from some treatment, and all you have to do is walk them over to the social worker or make an appointment at that same clinic the next time they come back for their checkup or whatever it is, the more likely they are going to access that and use that treatment than if you send them to an agency not embedded. We just know that to be true. It's more convenient, and they trust you, and there's a lot of things that make that just so much easier. So if you can do that warm handoff, I like that expression, and you've got people there at the ready to help you when these things occur, that really has been shown so far to increase people's access to behavioral and mental health services.
Thanks very much. We have another question in the chat, which basically said, can CBT skills also be delivered as brief interventions by either the primary care clinician or interested nurses or others within the practice? Anybody want to take that on, and let's hear what you all say.
So Dan, I was working on a comment in response to that question, and that is CBT can be offered and delivered as brief intervention. Our resources include a list of apps, and there are also self-help manuals like the Pain Survival Guide by Dennis Turk. But it's really important for clinicians to keep a few things in mind, and that is, first of all, to educate patients and set appropriate expectations for improvement, as well as monitor progress, and to refer folks to specialty care like CBT if needed, because some folks can become easily discouraged if their efforts are not successful. We've seen that a lot, just even teaching the deep breathing. That should be, it's a brief intervention. People can go home and practice, but people can actually practice that wrong. If they hyperventilate, it's going to turn them, it actually triggers panic attacks, right? Because people often don't know how to distinguish between the using the upper respiratory tract versus the chest versus the abdomen, and if they tend to have panic attacks, and they might already be a natural shallow breather. So that's just an example of why it's important to very closely monitor for success. And I just gave you an example of how people can sometimes misapply the skills. But brief interventions are certainly a way to offer broader access. And there are a lot of folks that, once they're sort of pointed in a direction, are good to go. So, there's definitely people for whom that's appropriate. Kim, did you have something you wanted to say about this?
No, I think you covered it.
Thanks very much, Fran. There's another question in here, which I think is very germane. Do the insurance companies play a factor in reasons for those who are unable to obtain treatment? If these services are not covered, number one is, can patients afford them? And how much does the access to care, are the services even available to patients? So
I can briefly address that from the primary care point of view. Yeah, it definitely does play a factor, because there's many patients that we do want to refer and are unable to because they don't have coverage. Fortunately, we are embedded counselor on our clinic now is able to be paid via Medicaid, which a few years ago was not an option. And I do know that there is another issue that with Medicare not paying for certain counseling, and I think maybe Kim can speak to that even more. So we do refer often to fully available sites such as Family and Children's Services. But there is not, as we all know, there is not enough care providers, mental health, behavioral health care providers available, but insurance definitely plays a part in limiting that, unfortunately.
I was going to say, though, one of the cool things about family medicine, working at the Tandy Y in sports medicine, is that they really incorporated some wonderful things with physical therapy, deep breathing, and some other things that really has enhanced, I think, some patient access to some things that they didn't have access to before. And just an additional aside, they're doing a study right now for the severely mentally ill, and having patients coming there for some extra care that they would not have received through exercise programs and things like that. So there are some exciting things happening over in sports medicine at the Tandy Y in conjunction with PTOT that I'm hoping will be extended to a whole host of people in the community.
I was sorry, Dan. I was just going to say that what we didn't talk about it as much today, but we do when we train residents and other people, particularly talking about ACEs in primary care. But the one thing that I would want to say to this group, since a lot of you are in primary care, is that what we do know is that even bringing up ACEs to a patient that you suspect might have a history of ACEs can confer a great deal of relief to those patients. The greatest thing about trauma and violence and childhood abuse is the shame and vulnerability and fear and silence that surrounds it. So Marty and other people that we have talked to have countless examples of patients who were very old or that they had seen on their patient load for a long time, and all of a sudden after they had this training thought to themselves to ask, and outpoured all of this information about a really difficult past. And some of those folks were healthy enough and were doing fine, and some of them weren't. But they often said, "You're the first person to ever ask me this," right? You know, I mean, and think about that for a 70-year-old woman or a 65-year-old woman who has finally been asked over her, you know, in her lifetime if she'd been abused. So that can confer in and of itself some validation and relief to patients, even if they maybe don't need to pursue, you know, additional counseling or resources. Just by asking can sometimes really help patients on the pathway to healing.
Thanks very much, Julie. Fran, there's a comment in here on the chat that I think is really quite interesting. And it says, first of all, thank you, Dr. Nguyen. I'd be especially interested to find out if CBT plus NSAIDs have a synergistic effect on acute or on acute or chronic pain. Do you want to comment on that?
Yeah, you know, I've been trying to answer that question by going on to actually some of our databases where we can search the literature. What I found is that the literature right now isn't sufficient for a really large systematic review to have been conducted. For example, there's nothing out there on Cochrane reviews, et cetera. I think clinically it makes a lot of sense because a lot of people need to have a pharmacological intervention to mitigate some level of pain in order for them to engage in some of the behavioral adjustments that they might need to. So for example, there's time-based pacing is an adjustment that people, it's an evidence-based treatment. That's part of cognitive behavioral therapy. But if people, and so you're asking people to engage in an activity like laundry for a certain period of time, rather than what we're used to, which is keep working until you're worn out. and you know, for people with chronic pain, that means they go into this cycle of pain exacerbations. And so if you're going to teach somebody and ask them to do homework and trying out time-based pacing, you have to give them something to help them feel a degree of pain mitigation so that they are willing to try out that behavioral change. So I think it makes a lot of sense, and maybe there's a future study in for you, Dr. Bartow.
Well, those are the only comments that have been in the chat. This has been truly a informative webinar. Thank you very much, Dr. Kim, Dr. Jelly, Dr. Wen, and Dr. Miller-Krebs. Do any of the panelists have any final comments?
One thing I would want to say is for those of you who are starting out pretty unfamiliar to this, it just takes time to incorporate it into a practice, so don't get discouraged, don't give up, and you'll find, I think, a year from now, 2 years from now, that you'll be much more comfortable with having these discussions, doing the referrals, and there's so much available now to learn more. So I'd encourage you to look to learn more about trauma-informed care in particular.
Thank you very much, Marty. Thank you very much to all of the panelists. One final comment I'd like to make is we had a lot of non-clinician primary care workers on the call today. And I think the message we want to leave you with is this is not a clinician-owned activity, that simply having conversations with patients when you're rooming the patient or you're checking in the patient may be really very important brief interventions for people. Likewise, we can remember what Julie Miller-Krebs told us. Think about our individual roles in the primary care practice and how by our behavior, the way we act, the way we rush, the way we actually take a blood pressure or other give an injection can actually de-escalate the anxiety, the trauma, and the pain. And our behavior and actions begin to amplify the message that the clinicians and others may give. Well, thank you so much for all your participation, and we look forward to working on this in the future. Bye now.